Welcome, everyone. Today, we're going to tackle a fascinating and often really challenging movement disorder, dystonia. We're going to break down how you, as a clinician, can recognize it, figure out what's causing it, and know exactly how to manage it.
Okay, let's just dive right in with the case. Because, medicine is all about patience, not just dry definitions. So, meet Alex. He's 14, super active, loves sports, but lately, something really weird has been happening. Every single time he tries to run, his foot just takes on a life of its own. It twists inward and points down. It's not painful, but, well, you can imagine it makes running pretty much impossible.
So, what is going on here? This is the core puzzle we're going to solve together. We're going to use Alex's story to build a mental framework for dystonia piece by piece, from just seeing the symptom all the way to a diagnosis and a treatment plan.
All right, section 1. Let's really break down what we're seeing with Alex. What is this bizarre movement? So the very first step in any clinical problem is to put a name to what you're seeing. And what's happening to Alex's foot is a dystonic movement. That's the term. All it really means is that a muscle is contracting and staying contracting, which causes this twisting motion or forces the limb into an abnormal posture. It's a perfect description for what Alex is experiencing.
So what's actually going on under the hood? Well, it's pretty fascinating. See, for any normal movement, like bending your elbow, your brain tells your bicep, the agonist, to contract, and at the exact same time it tells your tricep, the antagonist, to relax. It's a beautifully coordinated dance run by a part of the brain called the basal ganglia. But in dystonia, the basal ganglia is sending out bad signals. It's telling both the agonist and the antagonist muscles to contract at the same time. It's basically a muscular tug-of-war, and the result is that involuntary twisting movement that we see.
Now, we can get even more specific. We classify dystonia based on how much of the body is involved. For Alex, it's just his foot, a single body part. So we call this a focal dystonia. If, say, it involved his whole leg and arm on one side, we'd call that hemidystonia. If it was his neck and one arm, we might call it segmental. This classification is super helpful because it starts to narrow down the possible causes.
And here is one of the most bizarre and classic features of dystonia. It's something you should always ask your patients about. It's called a sensory trick. You might have a patient whose neck is painfully twisted to one side. That's called torticollis. And they'll tell you that if they just lightly touch their chin or their cheek, their head straightens right out. It's not about force. It's some kind of sensory input that temporarily resets the bad circuit. It's a huge diagnostic clue.
Okay, so now we know what it is. We can describe it. It's a focal dystonia. The next and most crucial question is why? Why is this happening to Alex? What is the root cause?
So, to figure out the why, you need a mental framework, a filing system, really. And pretty much every cause of dystonia can be sorted into one of these 4 big buckets. You've got primary dystonias, which are often genetic. Then there are dystonia plus syndromes, where dystonia is part of a bigger picture with things like Parkinsonism. Secondary dystonias are caused by something else, like a drug or a brain injury. And finally, paroxysmal dystonias, which are episodes that come and go.
All right, let's apply that framework to Alex. He's a kid, and he has a focal dystonia starting in his leg. Right away, that makes 2 possibilities. One from the primary bucket and one from dystonia plus, jump right to the top of our list.
And this brings us to a really critical decision point. We have to figure out if we're dealing with something like primary torsion dystonia or, and this is the big one, the don't miss diagnosis of dopa-responsive dystonia. They can both look the same at the start, a kid with a foot dystonia. But look at the treatment column. One is really tough to treat while the other responds beautifully, almost magically, to a simple medication, levodopa.
And this is a non-negotiable high-yield point. For your exams, yes, but way more importantly, for your future patients. Because dopa-responsive dystonia is so incredibly treatable, you must give a trial of levodopa to any child who presents with an unexplained dystonia. You just have to. Missing this diagnosis is a huge deal.
So, staying on this theme of treatable causes, let's talk about another don't miss diagnosis, this time from our secondary dystonia bucket. This is one you need to think about, especially in a young adult presenting with dystonia, Wilson's disease.
So another really important inherited condition to have on your radar is Wilson's disease. Basically, it's a problem with copper metabolism. The body can't get rid of copper properly, so it builds up in the liver and especially in the brain's basal ganglia. And that copper toxicity can cause all sorts of neurologic problems, including dystonia. And just like dopa-responsive dystonia, the reason we harp on it is because it's treatable. We have medicines that can pull that excess copper out of the body.
Okay, so we've covered a couple of really important inherited causes, but now let's switch gears to what is, by far, the most common cause of dystonia you are going to see, especially in a hospital or ER setting, and that is medications.
And we're going to explore this with another quick case because this presentation is very different and very acute.
This timeline is absolutely textbook for an acute dystonic reaction. The classic culprits are dopamine-blocking drugs, like the older, first-generation antipsychotics. Haloperidol is a prime example. It almost always happens within a few days of starting the med, and it's most common in young men. And let me tell you, it is terrifying for the patient. They come in with their neck twisted in a painful spasm, that's torticollis, and they can get what's called an oculogeric crisis, where their eyes get locked in an upward gaze.
Now, this is a true medical emergency. Not because it's usually life-threatening, though very rarely it can affect the larynx, but because of the sheer pain and terror it causes. You need to know this treatment cold. A quick shot, either IV or in the muscle, of an anticholinergic drug like benzotropine or even just diphenhydramine, yep, Benadryl, will break the dystonia. And the relief is rapid and incredibly dramatic. It's one of the most satisfying things you can do in an ER.
Okay, that was a lot. We've gone from the basic definition all the way to emergency treatment. So let's do a little rapid-fire review to make sure it all sticks.
First one, you've got a professional violinist. She develops a cramping in her hand, but only when she's playing her violin. What do we call that? Well, the clue is in the trigger, right? It's specific to a task. This is a classic example of a task-specific dystonia, sometimes called writer's cramp, or in this case, musician's cramp.
Okay, next up, a patient with Parkinson's is on levodopa. He notices that right before his next dose is due, he gets this painful twisting in his foot. What's going on there? The key is the timing. It happens right before the next dose. This is what we call an end-of-dose or wearing-off phenomenon. The medication level is dropping and the dystonia is breaking through.
And last one, let's go all the way back to the beginning. What is the fundamental problem at the level of the muscles in dystonia? Remember that tug of war? That's it. It's the simultaneous involuntary co-contraction of agonist and antagonist muscles. That's the engine behind every dystonic movement.
And here you go. This is your cheat sheet for exams, your rapid revision summary. If you're going to remember anything, remember this. We've got the core definition, the crucial childhood differential, those don't miss treatable causes, the most common cause you'll actually see, the emergency treatment, and that bizarre key feature, the sensory trick. So, what's the big takeaway from all this? Dystonia is just incredible, really. It shows us how our simple ability to move is controlled by this invisible, unbelievably complex symphony of signals in the brain. And when just one part of that symphony is out of tune, you get these dramatic physical results. It really makes you wonder, doesn't it? What other invisible brain processes could be creating equally dramatic but maybe less obvious problems for our patients?